I would like to thank the organizing committee of WCC and Dr. Jyotsna ma'am for giving me the opportunity to talk about the role of Sildenafil in preeclampsia and the possible potential therapies for preeclampsia. Preeclampsia, the development of new onset hypertension and proteinuria during is defined as development of new onset hypertension and proteinuria during pregnancy. Incidences varies, but overall incidences are around 3 to 8% of all pregnancies. The pathogenesis of preeclampsia remains unclear. The treatment options are also limited. The maternal syndrome of preeclampsia is characterized by systemic endothelial dysfunction. Agents that improve endothelial function may hold promise to alleviate the symptoms of preeclampsia, delay the necessity of preterm delivery, and improve the neonatal outcomes. The pathogenesis, the onion layer method of model of preeclampsia have been told about, wherein the main pathogenesis is the placental maladaptation, which causes placental hypoxia. Release of substances like already Dr. Venkatraman Garu has elaborated, like the SFLT1, endoglin and autoantibodies to angiotensin 1 are released, thereby causing endothelial dysfunction and onset of symptoms like HELP, proteinuria, and other symptoms. Before that, the preeclampsia is defined as the hypertension occurring after 20 weeks of pregnancy with, if it is associated with proteinuria, it is called preeclampsia. If no proteinuria is seen, gestational hypertension is the cause. Coming to the pathogenesis, in normal pregnancies, the maternal systemic endothelial function is enhanced by increased nitric oxide activity and resistance to vasoconstrictors. Whereas in preeclampsia, there is a decrease in nitric oxide, which results in hyperresponsiveness of the vasculature to vasoconstrictive substances. The reduced nitric oxide and cGMP signaling and increased activation of endothelin 1 system causes preeclampsia. The main feature of this preeclampsia is the decreased NO activity. Women with preeclampsia have reduced levels of nitric oxide metabolites in blood and amniotic fluid. Systemic inhibition of nitric oxide synthase in pregnant rats results in a preeclamptic phenotype, indicating the crucial role for nitric oxide in maintaining cardiovascular health in pregnancy. Therapies to preserve nitric oxide signaling could be beneficial to promote vasodilatation, reduce blood pressure, potentially enhance retroplacental perfusion in women with preeclampsia. Coming to the role of phosphodiesterase 5 inhibitors in preeclampsia, the phosphodiesterase inhibitors, sildenafil, was there for various indications before they were being tried in preeclampsia. In preeclampsia, these prolong the effects of nitric oxide signaling by inhibiting the breakdown of second messenger of nitric oxide, the cyclic GMP. These phosphodiesterase inhibitors cause systemic vasodilatation to reduce the hypertension associated with preeclampsia, improve the reduced placental perfusion that is thought to be the cause for maternal syndrome, and also improves endothelial dysfunction in myometrial vessels of women who have complicated pregnancies complicated by intrauterine growth reduction. Coming to the trials, the major trials have been animal studies. In the sildenafil treatment ameliorates the maternal syndrome of preeclampsia and rescues fetal growth in dull salt sensitive rats. It has shown to be improve the maternal syndrome of preeclampsia and blood flow to the fetoplacental unit, and providing preclinical evidence to support the hypothesis that PDE5 inhibition may be an important therapeutic target for preeclampsia. And the major trial that was done in the humans were though it's a small study that was done in UK, they have seen an escalating dose of sildenafil up to 80 milligrams TAD was tried in pregnant women beyond 34 weeks of pregnancy. They have shown that the dose was well tolerated and with no increase in the maternal and fetal morbidity and mortality, and also didn't prolong pregnancy duration in women with preeclampsia. Then the STRIDER trial is an ongoing trial wherein they are going to see for the primary outcomes is babies being alive at term gestation without any serious adverse neonatal outcomes. The secondary outcomes are the improved fetal growth, growth velocity assessed by ultrasound abdominal circumference measurements, gestational age and birth weight. The secondary outcomes also for mothers include coincidence and severity of maternal syndrome, of preeclampsia and mortality. The trials have started in 2013 and they are going to end in 2017. So the results are expected somewhere in 2020. Conclusions: the past two decades have greatly increased our understanding of the mechanisms underlying preeclampsia. Initiating cause remains unknown. The placental ischemia is the central agent in producing many of the detrimental symptomatic effects seen in the disorder. Effective therapeutic options for women suffering from this disease are still not available. Agents that improve endothelial function and directly target the systemic vascular dysfunction of preeclampsia hold promise. Available evidence from experimental animal studies support the use of PDE5s and endothelin receptor antagonists for the treatment of preeclampsia, which warrants of further investigation. Thank you.